think that's a great review, and certainly I know I can relate to that with differences in clinical practice between clinicians, even RDs, pharmacists, or physicians across the care spectrum. And I think that aligns a lot with what we view when we're thinking of like this particular study actually is what I see in practice. And you mentioned that there was this clinical difference in protein delivery between the groups, which we don't see in many of the observational trials because they weren't randomized. They were observational, or even in some of the smaller studies, we may not see this difference in protein delivery. So the difference we see between these two groups, you mentioned that this 1.2 or 1.5 gram per kilo per day at the high end for the high protein group approximates the limits of clinical care. So can you describe a little bit more about what you mean by that and how that really applies to our day-to-day practice?
Absolutely. The International Nutrition Survey, asked how much protein are you delivering? How much protein are you actually getting in? And what it found was that yes, they're prescribing 1.3 grams per kilogram per day on average, but they're only getting in about 0.7. And this is just everyday real world practice without the constraint of having a patient enrolled in a trial. So now you randomize patients to 1.2 or less, or 2.2 or higher, and you put them in the context of a study. And so because this patient's in a study, there's probably more eyes on them. There's probably greater attention that's paid in terms of getting the protein into these individuals. But despite that, despite being randomized in a trial to high doses of protein, it turns out that the best that we can do is still get in about 1.5 grams per kilogram per day. And so if within the context of a study, we can't achieve anything higher, then it probably means that outside the context of a study, we're probably not going to achieve much higher, unless, of course, that patient just has a team of eyes, on them, and they've addressed all of the other barriers to, delivering protein. And you and I know what all those, barriers are. There's patient-related barriers. There's system-related, barriers, and then there's provider-related barriers. And not to go into too much detail, but one of the biggest barriers is interruptions in feeding, right? And so when we interrupt feeds because our patients are going for a procedure, for example, that reduces the amount of nutrition that is delivered to these individuals. And so unless there's an organization that really has managed to reverse or really ameliorate all of these barriers, I find it hard pressed that we're going to be able to achieve much more than 1.5 grams per kilogram per day of protein.
Sure. And so I think, when we're looking at this particular study, we have the idea of this is real world. This is kind of the limits of what we're expecting real world. We know that there's these differences, not just in protein delivery, but also in energy delivery. Can you speak a little bit, and you touched on it, but can you speak a little bit about how in this particular study, because energy was not necessarily prescribed by the study group, how that plays a role in interpreting the outcomes and then applying those results to clinical care?
Yeah, we weren't prescriptive on the other co-interventions, meaning we didn't say you had to use this type of EN, you had to use this type of PN, you had to use this protocol for getting your patients extubated. You didn't have to use this protocol for resuscitating people with sepsis. But the only thing that we strongly encouraged was to keep the energy prescription the same. And if I recall correctly, the energy prescription, I think throughout was about 23 kilocalories per kg per day. But the reason to do that is because then we constrain that variable to not have an effect on that which was randomized, which is the protein. And so any signal of benefit or harm that we see, we can attribute then to the protein dose alone. But since you asked, I think we have some new data now that seem to suggest that higher amounts of energy delivered compared to lower forms amounts of energy delivered, at least it's not beneficial. And if anything, it's met with harm. And we're talking about things like enteral feeding intolerance. And this data, of course, comes from the recent Nutrivia 3 trial, which confirms what was observed in the Nutrivia 2 trial. But even before those, we had, of course, Permit, Eden, and Target. And I think we're moving towards a less is more strategy, at least during the early acute phase of critical illness.
Yeah, I mean, certainly that is, I think I can count on like my hands 10 times how many times a physician would ask me, like, how are you changing your nutrition support goal? What are you looking at? What's your target for knowing when it's safe to increase feeds to goal? And I think even just the difference here between enteral and parenteral nutrition, legacy thoughts where that TPN management early in critical illness may not be ideal. We know some more recent research suggests that there may not be differences between enteral and parenteral or supplemental parenteral in this phase. And with the effort protein trial, this was primarily enteral feeding patients. Correct me if I'm wrong here, but primarily enteral feeding patients. And I'm curious if you have an explanation for why this might be, and if it impacts application of the results for, let's say, PN patients.
I think if we look just kind of worldwide nutrition practices, so the International Nutrition Survey, they also asked, how are you feeding your patients, through what route? And the majority of sites reported enteral delivery. And so I think that was just an extension of what was already happening in real world practice. I believe 92+% use enteral feeding. And some of that is based on what guidelines tell us, right? If you can use the gut, use it. And there was a small number of sites that use parenteral nutrition. And I imagine some of those sites were using it because there was individuals who said, this patient cannot or will not receive enteral nutrition for one reason or another. Perhaps they were on high doses of vasopressors. Perhaps they were already exhibiting some signs of enteral feeding intolerance or other markers that may say they may not tolerate the enteral nutrition that I'm about to give them. But that's kind of speculation on my part. But I will say that there is alignment between what was observed in the International Nutrition Survey and what was observed with those same centers worldwide in using enteral nutrition.
Sure. And I think, one of the pieces that stood out to me in reading the publication was that some of the limitations in enrolling patients or allowing patients to enroll if they were potentially on TPN might have been because of product availability, whether a higher protein product was available or not. Do you think there was any, do you think that played any roles in sort of the tolerance and ability to achieve those protein and calorie targets? Because, prescribing versus delivery, as we know, are very different things. And you did achieve a fairly high protein delivery in the higher protein group.
I want my short answer, I think, would be I think so, because if there's just limited availability, and remember, many of these patients were enrolled during the pandemic,
Sure.
as well, where there may have been even more shortages in some of the parenteral, for example, formulations. So my short answer is I think so. I think that may have been one factor. I don't have the exact numbers, but I think there were few patients who were excluded for that particular reason, because I think having access to these formulations was sort of a requirement, for sites to actually be a part of effort.
And I think one of the other pieces that comes to mind too is, yes, that prescription piece, what is our goal? And then also many clinicians abide by the practice of, hey, I know my patient's only going to get 50 to 60% of what I target, so I'm going to target a higher goal with the intent that they might actually hit that, say, 1.5. Is that, how do you view that as a clinical practice strategy? Is that something that you've experienced or seen cause any benefit or harm?
I think it's going to have to be a site-by-site decision, because there's some sites, obviously, who, as you saw from the INS, who what they deliver is what they get, or excuse me, what they prescribe is what they receive. And if you are a site where historically you've audited and found that you're not delivering 100% of what you're actually prescribing, I think that's certainly reasonable. But I think it's a site-by-site decision, and it's going to be based on what you're prescribing and what you're actually delivering. And if the answer is anecdotal and I'm not sure, well, I think that leaves some room for harm to be introduced, because if you are prescribing a higher amount and that patient receives that amount, this signal for harm that was observed now in 3 randomized controlled trials would seem to suggest that, those patients are ultimately going to be, harmed.
Be sure to watch for upcoming Channel One videos on nutrition and learn more from our esteemed colleagues. Have a great day.